Welcome to part 12 of the Falcon Physician Review online anatomy components. Now we're going to move on with the vessels of the lower limb. Starting with the question, the lack of pulse in the dorsalis pedis artery would normally lead to suspicion of an occlusion in what artery? This would be the anterior tibial. The dorsalis pedis is a direct extension of the anterior tibial artery. And when you have pulselessness, you want to work backwards from that and find out at which site this would be blocked. If the anterior tibial artery were the blocked location, then you would have pulselessness in the dorsalis pedis. If you went back and felt the popliteal pulse and it was also absent, then you would start thinking backwards and go into the deep femoral or the anterior femoral components to work backwards from that. And if you had a posterior tibial that was blocked, you would not have a dorsalis pedis affected at all. So in general, the vessels of the lower limb, we have the internal iliac branches, which would include the superior and inferior gluteal, the obturator and the internal pudendal branches, all coming from inside the pelvis to get out into the various compartments of the gluteal and thigh region. Then we have the external iliac branches, which would go and become the femoral underneath the inguinal ligament, and that would give off a deep femoral, which would then travel down near the linea aspera of the femur, giving off perforating branches through to the posterior compartment. And then we'd have a medial and lateral femoral circumflex that we already discussed, with the lateral being more predominant towards the greater trochanter and the medial being predominated towards the femoral neck and head. The popliteal is going to be the continuation of the femoral, sometimes called the superficial femoral, and the popliteal will begin as the femoral passes through the adductor hiatus in the adductor magnus muscle, coming from the anterior compartment through to the posterior compartment, and the popliteal will run all of the way through the popliteal fossa, where it will immediately divide into the anterior tibial, which will go to the dorsalis pedis as discussed in the question, and the posterior tibial, which will divide in the deep posterior compartment to give off a fibular, and that will send perforating branches into the lateral compartment of the leg. Then it will continue down into the ankle, where it will become a medial plantar and a lateral plantar. Let's take a look at some of these. Again, if you need to spend more time reminding yourself of this basic anatomy, I think there's certain points of it that are worthwhile. If you've already got a good handle on this basic anatomy and remember it well, move quickly. Here you can see the common iliac dividing into an anterior, internal, and external iliac. Then the anterior division will be running forward, and the obturator nerve can be seen running through the obturator canal with its such named artery. Here you can see the superior gluteal dropping between the lumbosacral trunk and S1, which is an important landmark for it, both surgically and anatomically. So key into the location of that vessel because it's quite regular. And then you have the inferior gluteal and internal pudendal that will be leaving below the sciatic nerve and piriformis. Superior gluteal above piriformis, inferior gluteal internal pudendal below piriformis. Of course, the larger of those two is going to be the inferior gluteal, because the gluteus maximus muscle is obviously larger than your genitalia and would need more blood. Here's some of the nerve roots as they combine along the belly of the piriformis and formulate the sciatic nerve. This is a dissection picture showing a common alteration of the obturator artery. Here's the external iliac, and you can see the internal iliac, where typically you would have an obturator artery coming off and running with that obturator nerve going through the obturator foramen, but in this case there's a branch coming directly into the obturator canal off of the external iliac. This is known as an aberrant obturator artery. Oftentimes very susceptible during pelvic fractures, especially pelvic ring fractures. Superior gluteal and inferior gluteal can be seen plainly, and the nerve roots that are formulating the sciatic nerve. You can even see the belly of piriformis, and then the smaller vessel would be the internal pudendal vessel as it heads out below. All of the other vessels are going to be related to viscera, and since the viscera has been removed, there are just free-floating stumps of that. There are 3 phi compartments, and there are 3 exits for the vessels, each of which takes them into a particular compartment of the thigh. Number 1 is the obturator foramen and canal, which would take vessels and nerves into the medial compartment. Then there's the subinguinal hiatus, number 2, which would take things from the false pelvis and put them into the anterior compartment, specifically the femoral triangle. And then there's part 3, which would be the greater sciatic foramen, which will take things from the true pelvis and get them into the gluteal region. This is of particular importance for the internal pudendal vessels and nerves, as they'll need to get into the gluteal region before they have access to the perineum, which we'll discuss in pelvis. Let's talk a little bit about the femoral triangle. This will have significance in testing because there's a lot of procedural things that can go on in the femoral triangle. We'll discuss some of them in a little bit, but it's good to familiarize yourself with the anatomy of this area. Many of you will probably remember the contents as being naval. That's going to be from lateral to medial, the nerve, which is femoral, the artery, which is femoral, and the vein, which is deep femoral. Then there are going to be an empty space for and then a lymphatic space. That empty space with the small e is going to be a potential site of herniation of bowel that can slip through the femoral sheath that is encasing the vessels and potentially put pressure on the area of the vessels itself, and can give venous distension as a result of that by compressing the vein, as well as cutting off the bowel itself. So this is an important area for femoral hernias. A 62-year-old male patient complains of burning in his legs upon walking, which forces him to stop after only a short while. He can continue after a few minutes of rest. The Doppler ultrasound reveals a near complete blockage of the femoral artery just distal to the inguinal ligament, within the femoral triangle. What vessels could provide blood flow around an occlusion of the femoral artery at the stated level? For this type of question, think backwards one spot from where the blockage is. So this is a femoral artery block just at the inguinal ligament. Therefore, if we go back one level, we know that we're at the external iliac. Therefore, we're looking for a branch that would be off of the internal iliac. The inferior gluteal is the answer we're looking for in this case because it's the largest of the branches off of the external iliac. And we'll talk a little bit later about how it does that through the cruciate anastomosis that you need to be familiar with. But all of the other branches are going to be either too small, such as the obturator, and not part of the cruciate anastomosis, and the others will be distal to the blockage and therefore not useful as a bypass. So we'll look a little bit closer at the deep branches of the femoral artery. Here you can see the external iliac crossing over into the femoral triangle as the femoral artery, then giving off the profunda femoris, which is oftentimes giving off your medial femoral circumflex and your lateral femoral circumflex, typically which has an ascending transverse and descending genicular branch, which will contribute to the anastomosis around the knee but not to the femur. The profunda femoris will then go down in the anterior compartment near the linea aspera and send perforating branches through the intramuscular septum into the posterior compartment to supply the muscles there. The rest of the femoral artery will continue on down in the subsartorial canal and then go through the adductor magnus to become popliteal. Before doing so, it will give off a genicular branch which will anastomose with the knee joint, and then after doing so, it will give off genicular branches which will anastomose around the knee posteriorly. If we look around at the posterior aspect, then we're going to have the anterior tibial coming forward off of the popliteal, and the posterior tibial staying in the posterior compartment and then dividing into a fibular artery, which will supply the lateral compartment via perforating branches. So the fibular artery itself, is important to note, will stay with the tibial artery, posterior tibial artery, in the deep posterior compartment. Therefore, both of those are compressed in a deep posterior compartment syndrome. So when you get a deep posterior compartment syndrome, you not only lose the deep posterior leg, you lose the lateral compartment of the leg, and because you're shutting off anterior tibial, you'll also lose the anterior compartment of the leg. So with a deep posterior compartment syndrome below the knee, you're going to lose all of the structures below the leg, and this is a critical surgical intervention needed. Let's come back to the cruciate anastomosis based on the question that we asked earlier and see why the inferior gluteal is going to be a good bypass for blockage of the femoral artery. Here you can see in the anterior view that we have the deep femoral artery coming off and then giving perforating branches around to the posterior compartment, along with the medial and lateral femoral circumflex, which are going to be coming around to service the greater trochanter and the medial side, the neck and head. From a posterior view, you can see those medial and lateral circumflexes coming around to meet up with one another. They will be joined by that inferior gluteal branch as it comes from the gluteal compartment to anastomose with those vessels. And then the first perforating branch off of the deep femoral will send an ascending branch up, and together these will come together in a cross, which is why it's called the cruciate anastomosis of the hip. So the inferior gluteal branch is a branch off of the internal iliac, and the other three are branches off of the femoral, which gets contributions from the external iliac. Thus you have a bypass if the iliacs should get blocked in any situation. What happens if these get blocked too quickly, if this is a fast process versus a slow process, or through damage of the vessels through femoral neck fractures, is you can get avascular necrosis. Some of the contributing factors can be the angulation of the neck of the femur itself. If that angle is more 90 degrees, it's known as coxa-vara. If that angle is extended towards 120 degrees, it's coxa valga. The coxa-vara is a more susceptible fracture for femoral neck injury, whereas the coxa valga is more problematic for hip dislocation or congenital dislocations. The resulting fact of this image here is that you can see the avascular necrosis is starting to affect the femoral head, and this is in a postmortal view. In this MRI, you can see how the femoral neck has been fractured through because of the avascular necrosis that resulted through disease process. This will need a hip replacement surgery and cannot be met through just simple pinning. Now we'll move into the vessels and nerves of the leg, pull those structures together. You can see an anterior view and a posterior view with an interosseous membrane in between. We'll start on the posterior view and we'll put that popliteal artery coming down across the knee joint, and then it passes under the soleus, which is an important factor because it's under that soleus that it branches into the anterior and posterior tibial branches. So when it's under that soleus, the anterior will go through the interosseous membrane to get into the anterior compartment, whereas the posterior tibial will stay in the posterior compartment. I know I could never remember if there was an anterior and a posterior tibial artery and just one tibial nerve, or if it was a anterior and posterior tibial nerve and one tibial artery. And I needed something stupid to help me, so I always remember them by thinking tibial, and I automatically start thinking one nose, two arms. One nose for tibial nerve, and there's two arms, so I have two tibial affer arteries. So here we can see the anterior tibial artery and the posterior tibial artery. Then you can see the branch coming off of that, which would be the fibular artery, sending perforating branches around to the lateral compartment of the leg from the deep posterior compartment. And finally, we'll add in the nerves. There's the tibial nerve, one nose, two arms, so there is only a tibial nerve heading in the deep posterior compartment, and then that will cross the ankle joint into the foot to become medial and lateral plantar. From the common fibular around the neck of the fibula, there'll be a common fibular that branches into a superficial fibular, supplying the nerves to the muscles of the lateral compartment, and there'll be a deep fibular which will supply all the muscles in the anterior compartment of the leg, and then this will cross around and supply sensation to that first web space of the first and second digit. Remember, it's the anterior tibial artery which will become the dorsalis pedis. So these are popular sites for taking a pulse in the lower limb: femoral pulse, popliteal pulse, posterior tibial pulse, and dorsalis pedis pulse, each of which has a different indication if it becomes pulseless. The femoral pulse we talked about in one of our situations earlier with the blockage of the femoral artery under the inguinal ligament. This can be palpated when you go halfway across the inguinal ligament between the ASIS and the pubic tubercle and drop down about an inch. The popliteal pulse is the hardest to feel because of its deep nature, with the artery being set close to the bone, so you need to use deep pressure on that, and don't use your thumbs because of course they have their own pulse. The posterior tibial pulse will be located behind the medial malleolus, and the dorsalis pedis pulse will be just lateral to the tendon of the extensor hallucis longus tendon. When you have arterial occlusion, there's the 5 P's that you can think about. The first is pulselessness, or if the pulse is greatly reduced, especially compared to the other side. The second is paresthesia. Is there pins and needles associated with that pulselessness? Third is pain, oftentimes causing cramping. Fourth is pallor, which is lacking color. And fifth is paralysis, which will mean that the arterial supply has started to affect the muscles and the nerves. So when there's a lack of pulse, think of a blocked artery, just like we did in that earlier question. If the femoral pulse is blocked or has no pulse, think of the external iliac or the common iliac. If the popliteal is blocked, go back one level and think of the femoral for a pulse. Is it blocked? If the dorsalis pedis is blocked, think of the anterior tibial, which gives off the dorsalis pedis. And if the posterior tibial is blocked, think of the posterior tibial in the leg being occluded. Here's a question that we can work through. A 16-year-old male received a superficial cut on the lateral side of his foot while playing football. He is admitted to hospital where the wound was sutured. 4 days later, the patient returns to the hospital with high fever and swollen lymph. Which group of nodes will first receive the lymph from the infected wound? The popliteal nodes will be the first one to accept the lymph from this swollen and infected wound, and you have to think about the venous drainage in order to figure this out. The popliteal nodes are the first group, after which the lateral side of the leg and foot will be draining. The vertical group of superficial inguinal nodes is going to be a superficial group that is just prior to the great saphenous dumping into the cribriform fossa. The deep inguinal nodes will be trailing along the femoral vein, and the horizontal superficial inguinal nodes will be trailing from the ASIS region as well as the lower abdomen. The external iliac nodes will be deeper into the pelvis, as well as the internal iliac nodes, which will drain some of the deeper perineal regions. So this question requires that we review the veins and lymphatics of the lower limb. The popliteal nodes will drain areas below the knee and lateral and superficial. Once the lymphatics dive into a deep vein, then they will not come back superficially. So after they dive from the small saphenous vein, following that into the popliteal region, they'll join into the popliteal vein, which will then come back to the femoral vein, and that will be in a deep set of nodes. As far as superficial regions, the superficial inguinal nodes have that vertical set, which drain genitalia and medial and superficial thigh, and the horizontal superficial nodes, which will drain the inferior abdomen and the inguinal region. The deep nodes, again, will be draining the medial side of the femoral sheath, as well as the femoral thigh itself. Some of the clinical things to consider in this are going to be the varicosities, which from the Latin term varix, meaning twisted, and these are going to be because of incompetent venous return, typically from a dilation from pressure differentials between deep and superficial veins, which ends up widening and thinning the superficial vessels such that the valves are no longer competent to hold up that column of blood. They become painful, they itch, and they will burn, and they become prominent, as seen here in this extreme case of varicosities of the lower limb. When they become very extreme, such as this, they can cause skin ulceration, lipodermatosclerosis, and venous insufficiency. It'll happen about 15% of the time in men, and women seem to be a little bit more susceptible to this. It may have something to do with the muscle mass that they carry. It's not clear. Obesity definitely carries a problem and propensity for these, as well as genetics, age, and the habits you have. So oftentimes physicians or people who are on their feet for a long period of time will wear assistive clothing such as compression hose or shorts to assist them with venous return. What other kinds of vascular issues of the lower limb do we have? We have cannulation of the femoral artery, which is easily exposed in the femoral triangle for a coronary angiograph. The great saphenous cut down in shock, venous cannulation, can be possible by cutting down into the medial malleolus on the anterior side of the malleolus to find the great saphenous vein and put a direct needle into that. Then you can do a venous cannulation under direct vision of the vein and not have to worry about collapsing veins if somebody's in shock. Arterial embolisms are an important portion of the lower limb because arterial emboli can break free if they're in a vessel, and a piece of atherosclerotic vessel can create a blockage or a thrombus, and these can break off and cause atrial fibrillation. If it happens that these are occluded suddenly and no time for collateral circulation can develop, these can be deadly events. They can come in the form of a popliteal artery, and they can cause ischemia, which would require amputation. And we had a case earlier where a gentleman had to stop and rest, which is the result of intermittent claudication. And that's the condition where there's going to be a gradual occlusion of the vessels within the limb, usually because of atherosclerotic plaque buildup, and the muscles supplying the distal portion become occluded and deprived on blood, and when they become active, they start getting ischemic pain associated with typically the calf or sometimes in the posterior thigh and buttocks, and they need to stop until the muscles recover. Deep vein thrombosis, or DVTs, is a common and sometimes tragic result of venous complications that are lower limb issues that you need to be aware of for the step 1. They will occur when there's a blood clot, or thrombus is what you should call it when it's in a living person. Clots happen in dead people or when the blood is outside the body. And the deep veins of the lower limb can create these thrombi, And they're more dangerous when they're above the knee. When they're below the knee, they're not as much problem. But in those larger vessels above the knee, they can break free and be silent killers, as simple, painless swelling within the calf or the proximal thigh. And once they break free, that DVT could go on to the lungs and cause a saddle embolism. Oftentimes they're related to post-surgical issues, so be keyed to those during the fact that somebody seems to be having respiratory and gas exchange issues. Obesity, malignancy, pregnancy, postpartum, and the use of oral contraceptives are all keyed factors for development of DVTs. There are two main consequences. We've mentioned one, which is the pulmonary embolism. It can be oftentimes fatal. And the post-phlebitic syndrome, which is going to be back pressure of the deep veins causing venous insufficiency and ulceration of the legs. The superficial thrombophlebitis is going to be superficial veins causing clots, which will lead to inflammation and infection. These are not as dangerous as DVTs, but can be significantly painful for patients. So what you can have in a superficial vein, you can have in a deep vein. The superficial veins as grafts are going to be an important part of the questions that you'll see in the USMLE as well. Not only will they ask you which vessels can be used, but where they can be harvested. And usually the great saphenous vein or the small saphenous vein can be used. The great saphenous vein is typically harvested from the thigh region, and they have to be reversed so as the valves don't prevent blood flow. Veins are not as good as grafts as arterial grafts, and we'll talk more about that a little bit later. One of the other significant issues for lower limb vascular trouble is the diabetic foot. Nerve damage oftentimes happens as diabetic neuropathy, which really is a result of small vascular shutdown around the nervi vasorum, and these vessels will close down first, killing off the nerve, losing sensation, and then people develop cuts, blisters, and ulcerations as a result of poor foot maintenance. This can oftentimes lead to gangrene, is a major cause of amputation, and you can see some of those high pressure points when people are walking and don't have very good sensation to their feet. Oftentimes this reduced blood flow can be felt in the vessel's pulses, also with the temperature and color of the distal limb. They have decreased immunity, and if they have any previous damage to the bones, joints, or ligaments in the foot, these are also predisposing them to further ulceration. That concludes section 12 on the vessels and the vascular problems of the lower limb. In the next section, that concludes section 12 on the vessels and the vascular problems of the lower limb. In the next section, that concludes section 12 on the vessels and the vascular problems of the lower limb. In the next section, that concludes section 12 on the vessels and the vascular problems of the lower limb. In the next section, that concludes section 12 on the vessels and the vascular problems of the lower limb. In the next